Dr. Sclafani, it's nice to meet you. Thank you for being here today.
Thank you.
Where are you from?
New York City.
Where do you work? Where in New York?
I work in a community ambulatory center now. I used to be the chairman at Downstate Medical School, Department of Radiology. And in order to treat CCSVI, I decided to leave academia so that I could continue my research.
Why did you think it was important to treat CCSVI?
Because I didn't think the patients had sufficient alternatives, and that this was a worthwhile exploration to see whether it would help them. I was very skeptical for well over a year in doing that. It wasn't that I want to do this because this makes sense. I wanted to do this so that I could make a statement about whether it made sense or not.
What have you found so far?
I have found that there are distinct symptoms that seem fairly frequent that are related to obstructed veins in the neck, and that those symptoms tend to get better in patients after angioplasty. That they still haven't clarified my own mind which patient will benefit. I haven't got that part done yet, but I spent the last year and a half trying to develop what I considered the safest, optimum way to get the veins dilated. And that's not been a simple process.
How are you doing that?
How am I?
How are you determining the best method? I mean,
firstly, if you're going to treat this by dilating the veins, you have to determine how the veins can be dilated. So putting a balloon in there that's too small will not be very effective. Putting one that's too large will be damaging. So I had to figure out for myself what was the best methodology to make those judgments about the size of the balloon, the locations of the stenoses, finding the most stenoses I could. And it wasn't very simple. And since I started in 2009, and if I compare that to 2012, there's not one element of the way I do this treatment that's the same as I did it in 2009. Not one piece. Nothing. The contrast agents changed. How I anticoagulate and when I anticoagulate has changed. What types of catheters I use, what blood vessel I go into, what size balloons to use, what's the measure of successful angioplasty has changed. It's been a real learning. So thankfully we didn't and I didn't go to a randomized trial in 2009 because my outcomes are much better now than they were then.
Are you surprised by that?
My original thought was that this was just another vein that had a stenosis, and that if you did a balloon angioplasty like you do in other veins that are stenotic, you would have pretty much the same outcomes. And that was incorrect. There are nuances to the jugular vein that are not like the other veins that I've ever treated. And while I've treated jugular veins before CCSVI became of interest, the numbers are greater and the consequences are different. And the pathology is different than we imagined. I think almost everyone that I know thought we were dealing with a vein wall that had narrowed. I mean, it's mostly not like that at all. It's the majority of it's really in the valve apparatus, and that's what's stenotic. And it just takes a different strategy for that.
Well, it sounds like you've, kind of made a pretty significant career path change. And how and why did you make that shift? I mean, because this is fairly cutting edge.
I spent my whole career in cutting edge. I got lots of scars. I've been involved with lots of controversial things. So I was at the end of my path, and I needed a new direction, and this came along, and it seemed like a logical thing for a senior person with not much to lose who could withstand a lot of controversy without having his reputation dismissed. And it seemed like somebody needed to be a champion for the patient, so that's what I decided to do.
And why are you here? Why are you at the ISNVD conference?
You know, there's so many different perspectives on the approaches to the disease, the physiology of the diseases, and there's no one person that can have all the answers. So obviously I came to surround myself with experts who are as focused and interested as I am.
And what have you found so far at the conference?
That there's lots of different opinions, and there's lots of people who are really trying very hard to come up with a solution, and that none of us know it all.
And you're going to speak to us a little bit about the consensus workshop on vascular imaging and CCSVI, particularly intraluminal ultrasound. Can you tell us a little bit about what that is?
Intravascular ultrasound is really the word. IVUS is intravascular ultrasound, and it's an ultrasound probe that's placed within the blood vessel, and sound is emanated through the blood column, and as it hits the edge of the pool, so to speak, there's a ripple effect. So you can imagine just taking a wave, making a movement in a small pool, it bounces off and comes back. And the probe that sends out the sound brings back the sound and detects it. And so anything that's inside that vein will reflect sound. The wall will reflect sound, the valve will reflect sound, a septum, a membrane, a web. All the pathology is, for the most part, inside the vein, not on the wall of the vein. So it's useful for that as a diagnostic tool. Then, of course, it's really helpful in selecting the size of the balloon to use. Really the only logical way for me to do it. And our consensus was not just about IVUS, it was about the procedures themselves. So we had a very raucous 90-minute discussion in which we could agree on very few things. And in preparation for that, I sent out a survey to 84 interventionalists around the world that I know perform the procedure. And there was very little agreement in practice. So some people were using small balloons, large balloons, high-pressure balloons, low-pressure balloons. Some people were going from the right jugular vein, the right femoral vein for the puncture. Others were going from the left. And there were very few consistent patterns. There were a few, and I think that gave us the basis by which we could start to think about how to create a consensus, but we're very far apart from consensus on best technique. And I think that was really valuable to know that.
Is that unusual, or is it because of the stage of this work?
I think it's both. I think it's very common for operators, surgeons, endovascular interventionalists, to develop their own techniques, and they work for them. But what we really need to do now is take those techniques and compare them one against the other in trials, and then we'll know if it makes a difference. We know there's a difference, but does it make a difference is really the question. Does the difference make a difference? If you use high-pressure balloons versus low-pressure balloons, what will be the outcomes? And there were people that were alarmed in the room, I thought, that there was such a divergence of opinion about how to do the procedure. And one of the people stood up at the end and said, so what do we do? You know, should we send the patients to you or not? And the answer is, we're all trained in by different mentors, you know, and the techniques are different, and we're applying techniques to a vein that we haven't really have a body of knowledge on. For example, we know the best practice for angioplasty of the artery. It's a circular, consistent shape. It's got a thick wall. It's got constant high pressure flow. We know when it needs a stent, what size balloon should be used, what anticoagulation to use afterwards. But the jugular vein is is so different than where we've done most of our research. But, you know, there's 500 million people in North America, and, you know, we've got to come up with something that's particular for them. And that's a lot of work. That's a lot of effort by a lot of people to collaborate. And that's why we're all here, is we're hooking each other with each other's ideas, you know. People are casting and catching fish, you know, so to speak. So people have come to me and say, why don't we try this against this? And, you know, I think we have to learn those things in order to be objectively coming up with a best practice. And nobody's right or wrong at this point, and it'll all flush out. I'm just too into the blood vessels, so I use analogies that are fluid-based.
So from what you saw today and what you experienced, and obviously your own work over the past few years, where do you think your field is going over the next few years in terms of consensus and best practices?
I think that we'll see parallel developments. We'll have a few randomized prospective trials. Some of them may have sham arms or not. Some may compare this treatment to drug therapies. And I think there'll be other people who will be randomizing their patients to balloons 50% greater than the diameter of the vein versus 20%, and we'll, you know, which ones are going to have more complications and stuff. We'll have to do those trials. You know, those are studies that will optimize. So I see it, one, we've got to validate the main concepts, and I think there's a good chance that we will. And then we've got to work on best practice. We've done this before so many times.
So are you following models from the past to do this, or is this unique in its nature?
Like I said, I've been involved with innovation before. I've been called a lunatic fringe from Brooklyn for doing things that were different, and had people yell at me at conferences. So I'm familiar with this, and it's not pleasant. It's really difficult and lonely sometimes, but no, that's the way it has to be. You just have to be transparent, and you have to be energetic. The first thing I did was discover the best practices for controlling hemorrhage from injuries by blocking the blood vessels, by going through the blood vessels and plugging them up from the inside. And I had tremendous resistance. So I decided very early that the most logical thing to do was go to the resistance with data. So I didn't really present my data to radiologists. I presented my data to the surgeons who were taking care of those patients. So I think that's a strategy that we have, you know, we've got to encourage neurologists and other people who care for patients with these diseases to interact with us and hear what we have to say. And if I have to go to their meetings, I will.
And this particular diagnostic tool is one of several that are currently in use for CCSVI, correct?
This tool, though, the tools that we're talking about are IVUS. I know you want to focus on IVUS, but we have to talk about the whole thing. Is catheter-based instrumentation, often with guide wires, put in by X-ray vision, by looking through the body as we move them around. It is what is the procedure. Everything else is about how do we make the diagnosis. This is about how do we treat and how do we identify what we have to treat. And that's a real-time, minimally invasive procedure that includes a number of instruments. It includes guide wires, catheters, you know, the small tubes that we can put in through the body through millimeter incisions, and then direct them to the place where we have to look at the blood vessels, and then we have to inject X-ray dye through the tube so we can see what the vessel looks like. And then we use, some of us use intravascular ultrasound as a secondary way to look at the blood vessels, and we integrate all that information real time in the moment and make decisions about which instruments we put in to treat. So our treatments are, at the moment, largely balloons, for angioplasty, or stretching of the blood vessel to open up the areas and narrowing and allow the blood to exit the brain. And there are some other instruments that we use infrequently, baskets to snare guide wires and pull them up through totally blocked blood vessels. Stents are used on rare occasions for a number of indications. And those are the main instruments that we have right now. We need other instruments that we'll have to develop. You know, there may be some opportunities to cut off pieces of abnormal valves so they don't recur. We don't have those devices yet.
So you've come together here with colleagues and people that are also interested in CCSVI, and you know, your goal obviously was to try to at least discuss consensus. What happens now? I mean, how do you, everybody's going back and they're going to be crazy and doing their own individual jobs, and how do you keep this on track so that you reach the next stage?
Well, you know, you meet people. Last year I met somebody in UK who was into the physics of fluid dynamics, and fluid dynamics are really important in venous flow and making decisions about what constitutes obstruction to the flow and what's important to treat. And I just last week came up against a very challenging and very unusual case. So that connection immediately spread to an email to Dr. Schelling, Dr. Zamboni, and Dr. Beggs, and we had dialogue. That dialogue is ongoing. Just when we leave here, those dialogues, those are relationships that colleagues make that are really dynamic, and you know, we're already collaborating on a paper on it. You know, that's how fast things move now. You know, with electronic media, you know, it's pretty good. Now, in terms of the main goal that I was commissioned with here, which was to try to get consensus, we have a few things that we reached consensus, and we didn't have to discuss it. You know, everybody used a certain type of entry, and somebody used a certain other instruments, so those are pretty much done. We had a lot of disagreement on which blood vessels needed to be imaged, but for them there was no disagreement at all. So we have the framework to start. That's the basis to start, and now we'll go back, and as we meet colleagues here, I've added them to our survey database, and they'll be given the same survey, and we'll collect more data, and we'll have our framework to start. And then it's about education, people giving their points of view, and people will modify their behavior based on logic that they haven't thought about, for example. And perhaps some of those consensus will come relatively easily. Some of them won't. You know, when you look at the type of anticoagulation that's used after angioplasty, there is no consensus. People are using aspirin, or aspirin and Plavix, or Coumadin, or heparin, or aspirin and Coumadin, or aspirin and Predac. You know, many different things, and nobody has consensus. So we have to start to compare them, see which ones have the best outcome, publish that data, and hopefully people will be pulled into consensus through the facts.
Do you think a year, because obviously the next annual meeting will be February in Krakow, if you had a crystal ball and could look ahead, do you think a year will be enough time for you to see significant change and motion in this field?
Well, like I say, when I did this in 2009, I did it here, and by 2012, I was over here. So is this a very dynamic field? We had conversations in the hall, in addition to wonderful lectures, conversations in the hall about the significance of this and the significance of that. And, well, you know, sometimes it's not about an understanding, it's about what the thresholds are and what's safe. And if you have to do that all by yourself, it takes a really long time. But having conversations, you know, I kind of reinforced something I believe today just based on a conversation with two other treating physicians, which was, that's not going to do any good. So now I feel validated. Now, Obviously, that's interesting, but we really need to get data so that it no longer becomes about the opinion of a few who have done a lot of patients, because, you know, people did certain surgeries for 100 years, and all of a sudden we don't do that anymore. So things do change, and people do modify their behavior. So if I had to put a crystal ball out for Krakow, I think that we will start to see outcomes data on effectiveness being presented with more frequency. The data that will be acceptable for us to hear will have improved. You know, if you think about the last year's meeting, there were presentations that were unsatisfactory, but they were baby steps. And we learned today from neurologists what their expectations are in that research. And we will have to accommodate their expectations and needs in order to get their willingness to hear our words. They're not going to listen to what we want. And we may even be right, but we have to get them to listen, and then we can come back. But they've got to, you know, we've got to play the game. You know, we have to have the same tools and work through it. So it's not easy. You know, interventional radiologists, who are, by the way, constitute about 80% of the people in the world doing the procedure, they have a different, you know, perspective on how we assess what we do. But the neurologists won't accept it. And that's why there's not been any real movement in that consensus. So we'll have to play the game by the same rules, you know. And that's what I think you'll start to see. Even now, I can't wait to get back there, because some of the conversations are really unique and different. We just listened to a conversation by somebody from Asia. It's a very different perspective than the West. And they're seeing different things with jugular vein stenoses than we see in the West.
Why?
Good question. All we did is see it, but you know, when I say this a lot, so when Wilhelm Röntgen did his research and he put the X-ray beam on, you know, and he shined it on this plate of cyanide and platinum, and I forget what the other, cyanobarium platinum plate. It luminesced. So he turns on this machine, you can't see anything, and this thing lights up. Can you imagine what that was like in the turn of the century, in 1900? I thought it was rather dramatic, and people were like, you know, in a big frenzy over it. And they asked him what he thought when he saw that, and he said, "I didn't think I investigated." And that's, you know, I see people get up and walk. I don't see it every day, but I see it happen, and I don't understand why. And from the point of view that I was treating MS, I don't believe that anymore. I believe I'm treating something else. You know, that's my own sense, but I can't assert that to anybody. I've got to prove it. And it'll take time. It's not going to happen overnight.
What's the most critical takeaway? Have I missed any questions that you think really need to be addressed?
Not from my perspective, no. I'm okay.
Thank you so much, Dr.
Okay.
Sclafani. I appreciate it, and I know you want to get